Chapter 33, Myelodysplastic Disorders. So we'll go over what are they, where they're from, what does it look like in the peripheral blood and the bone marrow, how we make a diagnosis, what is problem with the cells, and how do we classify them. And you can see the list of classifications. What is the cytogenetic abnormalities, some molecular stuff, and what's the prognosis and treatment for MDSs. So what causes this? That would be nice to know. It's some kind of mutation causing problems with the stem cells, so it's a clonal disorder. Cells don't go right. It could be one cell line. It could be all of them. So it's very ineffective hematopoiesis. So it's not really considered leukemia yet, or myeloproliferative yet. So that's just abnormal, right? So the findings we have is just dysplasia. So eventually, what's going to happen, it is going to progress to acute leukemia, so that has to be monitored very carefully. So the cells aren't maturing, aren't dying like they should. So other factors can be that they're getting MDSs because of chemotherapy they got, or some occupational or environmental thing, they've been exposed to stuff, or it could be an inherited issue. I mean, these are so difficult to find out exactly what it is and how to treat it too. So most of the therapy related. Okay, moving on. So the onset can vary. I mean, it depends on the patient. Like I said, it can go to acute leukemia. So the biggest thing is just monitoring very carefully, doing molecular testing, and then the WHO, with this new classification 2022, came out with some guidelines on what to do. So first thing we have to do is look in the peripheral blood and the bone marrow. So we're just looking at various pictures here. And you can see at the top, the red cells start getting, funky looking. They're oval macrocytes. So it has what's called a dimorphic picture. In other words, we're getting two different types of morphology. So we've got small ones and big ones is what we're seeing. They're usually hyperchromic sometimes. Sometimes we'll see basophilic stippling. Sometimes we'll see Howell-Jolly's and Pappenheimers. The siderocytes will be seen. And then you can see the bone marrow, the ring sideroblast, has that blue staining. See where the arrow is pointing to it? Where the Prussian blue is picking up the iron, where it's actually wrapped around. And if you look at the ones across the bottom, the bone marrow, we get multiple nucleated cells, and they just have some wild nuclear shapes involved. And then there's like nuclear fragments. And then with the arrow, the bottom left, you see that little, they call it internuclear bridging, will be seen, which is very characteristic a lot of times for the disc erythropoiesis that we'll see in MDSs. So the peripheral blood, like we were just saying, characteristic, the oval macrocytes, hyperchromic microcytic cells, again the dimorphic because we're getting the macros and the micros, poikilo, so the abnormal shapes. I mean, you saw some acanthocytes, some burr cells, teardrops, basophilic stippling because the erythropoiesis is messed up, and again the Howell-Jolly bodies, the siderocytes are seen, the Pappenheimers are seen with it. And in the bone marrow, the multinucleated, the abnormal looking shapes, the nucleus is all kinds of stuff. It's got different lobes, busting off, bridging, and the ring sideroblast. So that's why those pictures are there, so you can see them. So usually looking in the myeloid side of it, we do have abnormal myelopoiesis, so it's dysmyelopoiesis. So usually what we'll see is persistent basophilia now. So now we're getting what's called an asynchrony between the nucleus and the cytoplasm. They don't develop in unison like they should. One is off. It's not following up. So a lot of times we can see what's called hyposegmentation. It's not Pelger-Hewitt, but it's fake Pelger-Hewitt. That's what's called the pseudo-Pelger-Hewitt. So you can see from the pictures there that the nucleus doesn't sort of match the way the cytoplasm is looking, and you can see how the red cells are all over the place. So, to emphasize, peripheral blood, the nuclear cytoplasmic asynchrony, the granulation, the hyposegmentation. And we do see hypersegmentation, so in other words, more than 5 lobes, like 6 or more lobes. And then that nuclear ring, we were just looking at that one. See the nuclear ring and that one at the bottom right. The bone marrow, same kind of thing going on. We're seeing the nuclear cytoplasmic asynchrony. The staining is not right because the cells ain't got what they're supposed to, because the granules are messed up. Our rods could be questionable, might not be seen. Again, the segmentation issues and the ring nucleus that we'll see. So then you get into the abnormal platelet stuff now. So you have dysmegakaryopoiesis. So it's just wild looking morphology. At the top you can see the bizarre looking platelets. I mean, they're like big and like stuff sticking off of them. The one in the middle is actually a megakaryoblast. It's a micro one, and you can see the cytoplasmic blubbing that's going off of it. And then at the bottom picture, you can see it's a megakaryocyte, but it's not normal. It's got stuff coming off. I mean, if you see it, you're like, oh my goodness, what is that? So it's just, grossly abnormal, but it does not fit the definition of an acute leukemia. It does not. It's just saying it's abnormal. It's probably headed that way, but it's not. So the dysmegakaryopoiesis, they're very large, mononuclear, which should be, multiple nuclei in a megakaryocyte. And they're smaller. I mean, you saw pictures. Megakaryoblasts are smaller. They can be bilobes. It's just they're not normal. They do not follow the guidelines of being normal. So how do you figure it out? Well, you sort of have to rule out anything else it could be. B12 folate deficiency, which is well known to cause nuclear cytoplasmic asynchrony. Copper deficiency, Fanconi is like a major inherited thing, so that should be picked up in childhood. Parvovirus B19 can cause it, so we can do testing for that. And then certain kinds of drugs and chemicals they have. I mean, people get exposed to stuff we don't even know it. So an excellent history, occupational, environmental history is important to try to pinpoint what's going on. So what do we do? So the granulocytes don't do what they're supposed to do. They don't adhere, they don't phagocytize, they don't go where they're supposed to, they don't respond to chemotaxis. The red cells don't live the 120 days now. They just don't respond to erythropoietin. The platelets, I mean, they're there, but they don't do nothing. Very abnormal cellular function that we run into with this for all the cell lines. Right? So we try to classify these, which is not easy. So there's FAB, WHO, and then there's an international consensus. In other words, you're trying to get all of it together to make it simple, which is not. So the FAB, again, this is for pure morphology. This is how we usually did it. We had what's called refractory anemia, what was called RA at that time. And then we have refractory anemia with ring sideroblasts, RARS. Then refractory anemia with excess blasts, RAEB. Chronic myelomonocytic leukemia. Refractory anemia with excess blasts and transformation. All right, so first of all, what is refractory anemia? In other words, you can give them all the erythropoietin you want, and it ain't going to increase it. It just doesn't respond to nothing. They're just going to be anemic. The only way you can get the counts higher is give them transfusions, which that can cause other problems too. So then it slowly progresses. So you have the refractory anemia. Now we have the ring sideroblasts. So we've got nucleated red cells in the bone marrow with all this iron. Well, the cells don't know what to do. They have no leadership, I guess you could say, and they just can't do anything. So you can see it just step by step increases. Now the one where it says refractory anemia with excess blasts and transformation, in other words, there's like 19 blasts in the bone marrow. So it's like right on the edge now of being acute leukemia. Now how fast does this go? All depends. Sometimes it's fast, sometimes it's not. We've got to find the cause. And half the time we can never find what the cause was. So the World Health Organization came out with its own little classification, of course. So they have myelodysplastic syndrome with single lineage dysplasia, which is like the refractory anemia, and now the MDS with multiple lineage dysplasia. So now we're getting the white cells and platelets involved, and now they have ring sideroblasts with single or multiple. So it's just like factual things is what they're looking at. And then we go to the excess blasts. Excess blast 1 and 2. In other words, the differentiation is 1. Going off the top of my head right now, I got a chart somewhere in here. It's only a few. 2 is right on the edge of getting to an acute leukemia, so we don't have 20 yet. It can be MDS with 5q deleted disorder, which makes it easier because you know exactly what it is then. And then unclassified, in other words, doesn't fit anything, which a lot of times that's what it hits. I mean, we can't figure out what it is. Now, it can happen in children. They have cytopenia because we can't figure out what else it is. So it's a syndrome. In other words, you got all the symptoms, but really not a well-treatable disease that we got to deal with. Other WHOs are CMML, which we talked about earlier with FAB. Atypical CML, in other words, it doesn't have the Philadelphia chromosome, it's now negative. Juvenile myelomonocytic. MDS, MPMs with ring sideroblasts and thrombocytosis, and then unclassified. So you can see now we're getting in the gray area. It's just the more information you can obtain, better testing done, better diagnosis, better treatment. It all depends. So other ones with, we know certain genetic abnormalities, like we said, the 5q deletion, really don't have a lot of blasts. The SF3B1 mutation and the MP53 inactivation. That is more of a tumor suppressor kind of thing that's going on with that. So some myelodysplastic have lower blasts. Some of them, the bone marrow is not there, so it's hypoplastic. Some of them have increased blasts, but it's still not leukemia. So, like I said, the testing is critical here. Now, for children, same thing. Do they have a lot of blasts or not? I mean, what classification? Is it an acute leukemia or not? So it can be this, did they catch it early? I mean, who knows? It's such a vague thing for us to have to go on. So the clinical features that we have to look at for MDS is looking at pure morphology. Is it a myelomonocytic looking look to it? Chronic one? Does it have neutrophilia? Does it have thrombocytosis? I mean, so we're trying to pinpoint it. And these classifications are constantly with newer testing, new molecular, new everything, is getting better idea as to what's going on. So some of the cytogenetic things that we see is, we look for the chromosome abnormalities. In other words, is it something new or is it transforming? I mean, we don't know. So you can see a couple of the molecular alterations, and you've heard me sort of mention these. I mean, we're not going to be talking about it, or testing on it, but these are some of the molecular stuff that you'll be seeing that's coming out. I mean, it's just more and more all the time. So we get into, the epigenetics. In other words, what gene expression without change to the DNA I mean, what is going on? Why the genes, the DNA is telling the changes in these cells. I mean, they think it could be different parts of methylation of the certain islands or the histones in the DNA that's going, or it could be the microRNA expression is not quite right. Because you can see the results in, these mutations that is affecting it. I mean, a lot of this is still, we're learning, still a lot up in the air about that. Your book goes in great depth, which we're not going to, explaining this. So the treatment all depends on what it is. And again, like I keep saying, you have to monitor this constantly for the patient because you don't know what's going to happen. So what's the prognosis? Well, you can see all these lists. There's a gazillion different prognoses. All depends on the scoring system that they look at. So everybody's got their own as to what's going on. Because it's hard to get a handle on because it's so vague. Everything's so vague as to what's happening. So what kind of treatment do you give? Well, they try to improve the quality of life. I mean, you don't want to have constant fatigue, bleeding, all that kind of stuff going on. So they give supportive care, nutrition, social, financial, maybe transfusions, giving them erythropoietin, thrombopoietin, colony-stimulating factors, Neupogen, Neulasta. You might have to give them some antibiotics, because they get infections easy. They might have, like you saw from the ring sideroblast, they got too much iron, so they might have to chelate their iron. Or it could be immunosuppressive therapy. The antibodies are just causing nightmare throughout the entire system. So again, monitor the patient, see what's going on, and the treatment will change. It's almost like daily. So there are a couple, and you can see a very low risk that are out there. Stem cell transplant, I mean, it seems like the go-to anymore. But again, therapies, hopefully, a lot of research being done trying to focus on how to control apoptosis as to what's happening with the patients. So, what is MDS? What are the general features? What leads to it? So what do we look for? So, it's a very vague chapter, because it's abnormal, but it doesn't follow the definitions of leukemic yet. So we just try the best that we can. So you can read the chapter and look at the questions, and we'll talk about it in class. If you have any questions, please let me know. Thanks.